Hello and welcome to the Ask the Expert webinar chat series hosted by the National Resource Center on ADHD. I'd like to welcome you today. My name is Karen Sampson-Hoffman and this is the second of 3 February 2014 Ask the Expert webinars. Today we are pleased to welcome Dr. Ericka Wodka, and she's presenting the relationship between ADHD and autism spectrum disorder. Dr. Wodka is from the Center for Autism and Related Disorders at the Kennedy Krieger Institute and an assistant professor at the Johns Hopkins University School of Medicine. Ask the Expert is a monthly series presented by the National Resource Center on ADHD, which gives the general public access to top clinicians, researchers, and other professionals. The National Resource Center is a partnership between CHAD and the Centers for Disease Control and Prevention and serves as the national clearinghouse for the latest evidence-based information on ADHD. During February, CHAD is offering a special Ask the Expert membership promotional offer. You can save 25% on your membership if you are joining or rejoining CHAD this month. And you can do this by using the promo code FEBA14. If you are currently up for renewal, please call CHAD directly at 1-800-233-4050 option and then select option 3 in order to receive this discount. This is a limited time offer and will expire on Friday, February 28, 2014, so act now to receive this discount. You can visit us at chad.org for more information on the offer. And now again I'd like to welcome Dr. Ericka Wodka. Dr. Wodka is graduated from Drexel University in Philadelphia, Pennsylvania, earning a master's in science in 2003 and her doctorate in 2006, both in clinical psychology with a concentration in clinical neuropsychology. Dr. Wodka completed her postdoctoral residency in pediatric neuropsychology at the Kennedy Krieger Institute and Johns Hopkins University School of Medicine. She joined Kennedy Krieger in 2008 as a pediatric neuropsychologist and licensed psychologist. Dr. Wodka is active in the mentoring programs at Kennedy Krieger Institute and participates in neuropsychological training of externs, predoctoral interns, and postdoctoral residents. She is the supervising neuropsychologist at CARD. For those of you who would like to ask Dr. Wodka a question following her presentation, written questions can be submitted in the questions box on your GoToWebinar toolbar as indicated by the red arrow shown in this slide. All questions are moderated, and we will try to get to as many as possible during the question and answer portion of the webinar. A recording of this webinar will be available at www.helpforadhd.org within 48 hours, 2 business days. And finally, following today's webinar, you will receive an email with a link to offer us feedback on this webinar. Please take a couple of minutes to let us know what you think and how we can better serve the ADHD community through the Ask the Expert webinar series. And again, I'd like to welcome Dr. Ericka Wodka. Dr. Wodka, when you're ready, we are all set.
Great, thank you for having me. So next slide. So I've been asked to talk about the overlap between ADHD and autism spectrum disorders. And to do that, it's first critical that I describe the way that we assign diagnoses as clinicians. And we do this by a book that's called the Diagnostic and Statistical Manual of Mental Disorders, which, so I don't have to say that multiple times, we'll refer to as the DSM as it's referred to. And this is the authoritative guide for diagnosing mental health and developmental conditions. And it describes symptoms, criteria of conditions, the course, and the prevalence. And what this does is it allows clinicians to provide diagnostic labels so that individuals can be grouped with other individuals who share similar behaviors. And we do this so that we can provide treatments that are known to work with people with similar presentations. And we can also guide our research so that we're studying individuals with the similar presentations as well. What's really important, though, to emphasize about the DSM is that clinically significant impairment has to be realized by that individual in order to provide any diagnosis. Because there, as we know, is a range of typical behavior. There are certainly people, since we're talking about ADHD today, who have trouble paying attention, or people who are not the most social butterflies when we think about people with autism. But these people don't really have impairment, and so they haven't been diagnosed with things like ADHD and ASD. However, but when the impairment is realized, then those boundaries of normal behavior have been broken, and it's appropriate to provide a diagnosis to describe the behaviors that an individual is experiencing. Next slide. So as science and thus clinical practice advances, it's important that our diagnostic manual be updated, and that's what's reflected in the move from DSM-4 to DSM-5. And DSM-5 was released in May of 2013 with an emphasis on a lifespan approach, accounting for the fact that many disorders may present in childhood but continue to impact the individual into adulthood and may present a little bit differently in childhood versus adulthood. Next slide, please. In particular, I've been asked to talk about how these changes impact autism spectrum disorders and ADHD. Some notable changes were made with regard to autism spectrum disorders from DSM-4 to DSM-5. This slide shows the gross criteria of the pervasive developmental disorders in DSM-4. Autism diagnoses were falling under this category of pervasive developmental disorder, or PDD, in the previous revision of the DSM. The umbrella that's on the left of the slide shows the disorders that fell in that category. And those three disorders on the left side of the umbrella are the more common diagnoses that many of us have heard of, including autism, Asperger's disorder, and PDD-NOS. And just to be very brief in describing what these disorders are, autism required a specific severity of symptoms in three core defined areas, and those are the blue, green, and red on the right of the screen. So deficits in social interaction, communication, including a delay, and restricted and repetitive behaviors. In contrast, Asperger's required no delay in early language development and typical intelligence, but still required that symptoms be present in each of those three core areas. Finally, PDD-NOS was used to classify children with some of these symptoms, but not enough to reach the diagnostic threshold for either autism or Asperger's. The two disorders on the right of the umbrella, Rett's disorder and CDD, are less common disorders and involve a period of typical development followed by a severe regression and then presentation at some point with symptoms associated with autism spectrum disorders. Next slide, please. Moving to DSM-5, you'll see that term PDD was removed and it was changed to ASD, which collapsed the diagnoses of autism, Asperger's, and PDD-NOS into one diagnosis, autism or autism spectrum disorders. The DSM-5 also removed Rett's disorder and CDD from the autism spectrum for reasons I'm not going to fully cover in the scope of this talk. What you'll also see is that the three core areas were collapsed into two areas, where social and language difficulties were combined to reflect the relationship between social functioning and communication. And the relationship of social and communication that is actually core to the disorder. Abnormalities in sensory functioning were also included as a core symptom and fell under the repetitive behavior category. And finally, the onset of diagnosis, or onset of symptoms, I should say, was relaxed to capture children who may not present with early deficits, but who experience difficulties when demands for flexible language increase and exceed their abilities. And this can be seen especially for children with higher functioning autism. Next slide, please. So while it might seem that collapsing three disorders into one, autism spectrum disorder, would kind of lump a whole bunch of different children together who are more dissimilar than similar, we're also able in DSM-5 to provide specifiers which help better describe the child. So when we provide a diagnosis of autism spectrum disorder, we now have the option to specify all of the following that you'll see on the screen. So the range of severity of autistic behavior, the range of intelligence, intellectual functioning, the range of verbal functioning, meaning is the child speaking, do they have signs, are they able to communicate, the range of pattern of onset, so was this an early onset or was it a later recognized, the range of outcome, the range of comorbidities, and that we'll discuss in the context of ADHD as one of the possible comorbidities, and the range of etiological factors, meaning genetic or medical or otherwise. So all these specifiers can be then attached to the autism diagnosis to better describe the child. Next slide, please. So switching gears to ADHD, there are also some changes made to the criteria in DSM-5 as well. First, focusing or reflecting the lifespan emphasis of disorders in DSM-5, more examples are provided in the DSM-5 of adult symptomatology, so what adults present, how adults present with ADHD. The two behavioral categories were maintained, so inattention and hyperactivity impulsivity, as was the requirement for symptom presentation to be present in 2 or more settings, for instance, home and school. The age of impairment, however, was increased from 7 to 12 years. So in the previous DSM, impairment had to be, or symptoms had to be observed before age 7. But that's been relaxed a little bit, and symptoms still need to be present before age 7, but the actual impairment doesn't have to be evidenced until age 12. The other big change was that there used to be an exclusion that ADHD could not be diagnosed at the same time or in the same child who has an autism spectrum disorder or a pervasive developmental disorder per DSM-4. And that exclusion was removed, meaning that currently, as per DSM-5, a clinician can diagnose one child with both an autism spectrum disorder and ADHD. Next slide, please. So you might ask, why was it previously not allowed for a diagnosis of autism and ADHD to be provided for the same child? And this is, for the most part, because the vast majority of children with autism also do have difficulties with attention that don't necessarily warrant a separate diagnosis. So kind of like this giraffe and zebra, they're coming together. If you have autism, you likely have difficulty with your attention system. Next slide, please. However, the inattention that you often see in children with autism is somewhat different than that which is characteristic of ADHD. And so, for instance, if you think about a child with ADHD, they can often be withdrawn. They might be described as in their own world, and their attention is such that they exclude more salient environmental stimuli. So, for instance, a child may be in a classroom listening to a lesson, or supposed to be listening to a lesson, but really they're focused inward and they're thinking about something and they're excluding what's going on around them. Versus if you think about a child with ADHD, they're often distractible and they're drawn actually to environmental stimulation. So you don't want to sit them near a window because they're going to be the first ones to look out it. So it's not that they're distracting within themselves. What's going on around them is distracting them, again, from that same teacher, but for different reasons. Similarly, children with autism are often inflexible. They have difficulty shifting from one topic to the next, versus children with ADHD can often be described just the opposite as impersistent. They're often moving quickly from one topic to the next. They can't stay on topic. Again, the child with autism might be hyper-focused on details, and they miss the big picture of something, versus the child with ADHD has trouble sustaining their attention. They can't follow through in the same way, versus a child with autism will follow through if that is something that they're interested in, to the point where they will not do other things. Next slide, please. So in DSM-5, we can separately diagnose these two disorders, particularly when difficulties in both types of attention and behavior regulation, so the impulsivity and hyperactivity, are observed in the child. It's certainly possible that the child has both autism and ADHD, and that these are two separate disorders that are co-occurring. So, like our friends, the giraffe and the zebra, who now are living separately, but both still exist. It's really critically important to evaluate and evaluate for both of these conditions and recognize them, because treatment approaches for the two disorders, they can be different. And thus, if the child has a dual diagnosis, meaning they have both ASD and ADHD, there may be separate understanding and treatment for the individual disorders that is necessary, as well as for their overlapping and interacting symptoms. So I don't think that there's been a huge clinical shift in that these two disorders haven't always been evaluated for in the same child. It's just now technically the diagnostic manual is allowing the clinician to provide both these diagnoses in the same child. So next slide.
Well, our next slide brings us to our questions box. And for our participants, again, to ask a question, you can enter it now. We are taking questions now. And we are ready with our first question, and that comes from Lisa. And Lisa was wondering, what type of behaviors would you expect to see in a child who has a dual diagnosis of both ADHD and ASD?
So the behaviors would be the kinds of behaviors that you would see in the two disorders respectively. So if a child has autism, we would expect to see deficits in social communication, so difficulties making friendships, maintaining friendships, difficulties with reciprocal conversations, so not having that natural back and forth flow in their social interactions, as well as the repetitive and restricted behaviors, so things like hyper-focused interests, so being very focused on a particular topic, for instance, space, let's take. And so that child might be very, very focused on space, or they might engage in repetitive motor mannerisms, so those stereotypies, pacing, rocking, flapping, and or they may experience abnormal sensory functioning, so being super sensitive to loud noises or textures. And so they have the characteristics in both of those two domains, but then they also have the pattern of inattention and or hyperactivity impulsivity that's a separate difficulty. So they cannot, under any circumstances, sit still, or they're so impulsive that they're not able to inhibit behaviors, or they have really difficult time sustaining and maintaining their attention. And it's more than just that withdrawn attention difficulties that you see for kids with autism. It's in addition to that. They have trouble not only kind of disengaging from their own thoughts, but they have trouble inhibiting being kind of distracted by everything in the environment, and inhibiting their impulses, and trouble sitting still, and all the classic things you would think of for a child with ADHD as well.
Thank you. Well, our follow-up question comes from Mona, and she was wondering if you could explain just very briefly how ADHD and autism are related, or are they related, or could they be co-occurring disorders that simply are walking together, such as your zebra and your giraffe?
So they're related in the way that they're both neurodevelopmental conditions. So they're manifest, basically, they're reflecting brain development through behavior. So we know that the brain controls our behavior, and that there are differences in the way the brains of children with autism and ADHD, and or ADHD, I should say, develop. So they're similar in that they're both tied to brain development. We're not going to be able to identify the specific region of the brain that may be affected in an individual, but through group studies research, we know that there are differences in the connections and in the way the brain has developed in both of these disorders. So they're related in that way, and they're related in some ways in the way that they're treated, in that some supports that would be environmental and behavioral supports that would be appropriate for a child with ADHD may be appropriate for a child with autism, and vice versa, depending on their level of functioning. So it is possible that there is kind of a single neurodevelopmental condition that results in both of these behavioral phenotypes, or it could be that they are two separate things, and I think it just really is dependent on an individual child, and there isn't a way we can really give an answer for everybody. But we know that the rate of ADHD co-occurring with autism is higher than the rate of ADHD alone, meaning a child with autism would be more likely to present with ADHD as a comorbidity than just a typically developing child would be to present with ADHD.
Well, Lisa has another follow-up question to both of these questions, and she was wondering, what are the treatments for a dual diagnosis of ADHD? How does a practitioner and a family go about addressing both conditions together?
Well, I think the first step is careful evaluation to be certain that is what the child is presenting with, and then the treatments would involve both behavioral environmental modification and evaluation for potential medication as well. So it would be kind of the typical treatments that you would apply to the disorders individually. It would just be combining them to address all the symptoms that the individual child is presenting with.
All right. Well, our next question comes from Miriam, and she is following that question about treatment with a question about medication, and she was wondering, why is it that ADHD medication seems to help with ASD symptoms?
That's not typically what I guess I can't really answer that, because that's not what the science would inform. We don't typically think that stimulants help with autism symptomatology or the ADHD medications. That's not typically what the research has shown. I know that every child is different and responds differently to medication, and that's part of the challenge in providing medications, that children can respond differently. But typically, the medications used for ADHD do not necessarily improve symptoms of autism.
Well, that is a good thing for a lot of people to know. They are, again, different disorders with different treatment approaches. Well, we have a question from Christina that's going to follow on that one. And her question is, are there potential problems between potential problem interactions between risperidone and a stimulant medication, such as perhaps Adderall? And we have heard at the National Resource Center of people being prescribed both medications. Do you know of a potential problem, or is there a resource that people can check with first?
So as far as a resource goes, I think it would be important that the person that's prescribing the medication, be able to answer that question. Specifics about prescribing medications are kind of outside my area of expertise, so I wouldn't really be able to speak to specifics about the medications and their side effects and their dosages and things along those lines. But I think the answer to that would be you need to have a conversation with whoever's prescribing those two medications, and they need to be able to provide you with that kind of clarity before you give anything to your child.
Well, being aware of medications and having that ongoing conversation with the doctor and sometimes even the pharmacist to make sure is always a wise move. Well, our next question is coming from Natalie, and she was wondering what kind of specialist is most capable of diagnosing both ADHD and ASD as they're co-occurring together. Who is the specialist that a parent should be looking for?
There are different several different kinds of specialists that would be qualified to do so. It certainly is a specialized diagnosis, dual diagnosis even. So typically, at least at our center, we have children who have not yet been diagnosed with autism and or ADHD or fill in the blank, but are presenting with the question, does my child have autism, or do they have something else, or do they have autism and something else? We typically have them see more than one professional to kind of get more than one set of eyes and opinions on what the child is presenting with. Typically this would include psychologists, and or speech-language pathologists and or medical doctors, particularly developmental pediatricians, neurologists, and or psychiatrists. But those are the typical professionals who would be most qualified to assist in that diagnosis.
All right. Well, in addition to that, we've got a question. We've got two questions actually that are going back to the DSM-5, and they're coming from Corinne and from Lorna. And Corinne was wondering if there is still a combined type ADHD listed in the DSM-5, and Lorna was wondering how can someone differentiate between ADHD inattentive presentation and autism spectrum disorder?
So the answer to the first question is yes. The combined presentation is still provided. There's combined, there's predominantly inattentive, and there's predominantly hyperactive impulsive. And basically, as I had mentioned before, the two behavioral domains of ADHD were maintained, and so a child to qualify for the combined type would have to have 6 or more symptoms of inattention and 6 or more symptoms of hyperactivity and impulsivity. As far as differentiating between the predominantly inattentive presentation and autism, so children who present with inattentive ADHD, yes, they do have similar attention difficulties as children with autism. They're easily distracted, they can be forgetful, they can be daydreamy, they have trouble sustaining their attention. However, they would not have the social difficulties necessarily, or the same kinds of social difficulties, because I don't want to take away that children with ADHD certainly can have social difficulties, but it's not the same kind of social difficulties that a child with autism would have. So again, a child with predominantly inattentive ADHD would still have, a lot of social interests, would still, be making attempts at having friendships, would still be socially reciprocal, meaning, still have that more natural back and forth social interaction, versus a child with autism, would not have that. Similarly, a child with inattentive ADHD wouldn't necessarily have the repetitive behaviors and the restricted interests that you would expect that a child with autism, is required to present with. So again, the being really focused on one particular topic, getting stuck on topics, engaging in the motor stereotypies. So a child with ADHD inattentive wouldn't have, maybe they could have some of those symptoms, but they wouldn't have the number or the severity of symptoms that a child with autism would present with.
Well, we have one more DSM-5 question, and this is a bit related. This is more related to autism spectrum disorder than to ADHD, and it's from Laura, and she was wondering if you could address briefly why nonverbal learning disability and fetal alcohol syndrome are now falling underneath the ASD umbrella. Do you know anything about that? Could you share just a little bit of information?
Would you be able to repeat that question for me? I'm sorry.
Sure, no problem. Our question is, under the new DSM-5, nonverbal learning disability and fetal alcohol syndrome are now being gathered underneath the autism spectrum disorder umbrella inside the DSM-5 rather than being separate standalone disorders. She was wondering if you could address why that decision was made or how these two may relate to autism spectrum disorder.
So, nonverbal learning disability and fetal alcohol syndrome are not under the autism spectrum umbrella in DSM-5. Autism spectrum disorder is the only diagnosis under that category. So that I guess that decision was not made. So as far as nonverbal learning disability goes, that is a I don't want to call it necessarily a diagnosis, but it is a constellation of symptoms that has been described that do include difficulties with visually based skills. So again, nonverbal, visually based skills, and these children are also described to have social difficulties. So there is some overlap between children who have been identified as having a nonverbal learning disability and autism, but it was not included. The nonverbal learning disability was not included in the DSM-5.
That is important information for a lot of families. There's a lot of information that has been released on what is in the DSM-5, what is not, how things have been changed, and sometimes in gathering that information we end up on some tangents that may not be accurate. So thank you for answering that question. So we have another question. Sure. All right, we have another question now from Eric, and he was wondering, in the relationship between ASD and ADHD, are they currently thought to be on a single spectrum, or are they completely separate disorders? So could some people perhaps see ADHD and ASD as being on different edges of the same line, or are they on different tracks entirely?
So they are considered on different tracks. They are not considered on the same spectrum.
Right. Well, again, that's something that sometimes parents hear, that perhaps they're on that same track, and it's good to know that they are not. Well, our next question now comes from Wendy, and this is one that we do hear pretty frequently at the National Resource Center. And she was wondering if a school system can diagnose a child with autism spectrum disorder and ADHD, or is this only something that a medical professional, someone who is a specialist in ADHD, able to do?
Sure, that is a good question. So, and I will try and answer it without adding more confusion to the pot. So, as I described, the DSM is the manual that is used by and put out by the American Psychiatric Association and is used by professionals in the medical and clinical field to provide diagnoses. And it is a large book of several hundred pages that describes diagnoses including autism and ADHD, and the things that typically present in childhood to things that typically present in older adulthood, including dementias and other adult disorders. So it's kind of like I said earlier, the authoritative guide for providing diagnoses in mental health and developmental conditions. So we, as a clinician and as a licensed professional, have the ability to use this guide to make such diagnoses. In contrast, folks in the school, including school psychologists and other allied professionals, need to provide what's called an educational classification to provide a child with educational services, typically through an IEP. an individualized education program. And so they have 14 classifications to choose from. One is autism. One of the 14 is autism. And another of the 14 is something called other health impairment, which is where typically ADHD would fall. Some of the other 14 include things like hearing impairments, speech language disability, specific learning disabilities. So it covers the range of difficulties a child might experience as it impacts their education. So that's where the importance is. So you can, go to a professional out in the community, and your child may receive a diagnosis of ADHD, for instance, and you bring that to the school system and they say, okay, well, I see that your child has ADHD, but this isn't impacting their education or their academic functioning. So it's up to the school then to do that kind of evaluation in kind of their setting, or to accept the evaluation you brought in to determine whether A, there is a disability there, and B, is it impacting their education. And so we often get referrals here at our center for parents who say, the school has said my child has autism, but I'm not sure. They're not, they didn't say they're giving an official diagnosis. They're, giving them this educational code of autism, but I don't know if they really have autism or not. Can you guys do an evaluation? And so, that's perfectly appropriate to get further understanding of your child in that way. But so what the school has done in that case is they've provided the educational coding of autism, meaning that from their observations, they've met the educational classification of autism, and that's impacting their education, versus what someone would do in the community or a medical professional would do would be to use the DSM standards to make that diagnosis. So it's not, again, I hope I didn't confuse everyone more, because it is a little bit, there is a bit of overlap there, but there is some difference as well.
There is some difference, and we often hear from individuals when we're talking about ADHD where they ask, well, can't the school diagnose it? Why isn't the school doing this? So it is a very common question where we do have to explain that as far as ADHD is concerned, it is a medical diagnosis, and therefore a professional in the field, a clinician such as yourself or a psychiatrist, medical doctor would have to do the evaluation. The school cannot. So our next question is coming from Tim. And his question is, he's wondering if you can discuss the best treatment options for autism spectrum disorder, and if these treatment options overlap with ADHD treatment, or do they help with ADHD?
So that's a very broad and difficult question to answer, because it really depends on the child's level of functioning. So if you go back to this, if you can think back to the slides, a child with autism can have a wide range of functioning, and we have all those specifiers now to describe what that range can look like. So the treatment for a child who, let's say, has autism, is nonverbal, has a low IQ, and is pretty significantly impacted, would look very different from what the treatment would be for a child who has autism, who has fairly mild symptoms, whose intelligence is typical, who's verbal and able to communicate, but still, is experiencing difficulties functioning in daily life due to these symptoms. So, I think that speaks to, versus, I guess before I get into that, versus for a child with ADHD who, again, can have different levels of needs and abilities, again, requiring different levels of support. And so, I think it speaks to the importance of really being able to have that evaluation first for your child, to really understand what your child's strengths and weaknesses are, so you can understand what their needs are and what kinds of supports are going to be most effective for them. Where I always say you need to meet your child where he or she is, and so in order to do that, you have to know where they are functioning, and so you want to really get a better understanding of your child's abilities and needs, so that you can tailor those interventions and supports to their levels.
Thank you. Well, our next question, we're moving from the treatment to, this is one that we have many of our participants have been asking or asking a similar question, but can you touch on some of the comorbid or co-occurring disorders that are occurring with ADHD, with autism spectrum disorder, things such as anxiety or depression? You know, just touch briefly on that.
So, yeah, certainly with either autism or ADHD, co-occurring diagnoses can include anxiety, as you've already mentioned, other mood disorders as well, learning disabilities, language disorders, tic disorders, behavior disorders, things like oppositional defiant disorder, conduct disorder. Those are some of the more common comorbidities. And just like teasing apart autism from ADHD and whether it's, you know, two separate, you know, is this a comorbidity or is it just one or the other, a thorough evaluation should include evaluation for all those other comorbidities as well, because a child with anxiety and ADHD can sometimes present similarly to a child with autism, and it's very, very important to disentangle all those symptoms and really understand what is driving the behaviors that you're seeing. Is it truly autism, or is it ADHD and anxiety, and maybe even some language difficulties as well? Because again, you know, the treatments that we would set up might be slightly different given what the diagnoses are. And so so yeah, a good evaluation should be considering all of those potential comorbidities and or what we call rule-out diagnoses and their overlap to understand really how the child's presenting, so that the treatment plan can be created that's best suited for that particular child. I mean, I think I keep going back to it. It's, you know, it's the evaluation is so important, because that really lays the groundwork for what happens next.
All right, well, thank you. To follow up on that, Jamie has a question, and her question is, she's wondering, where does aggression fit in co-occurring with ADHD or with ASD, and why do some children display aggression? Is it related to the disorders? Is it related to frustration, and how can it be treated in a clinical setting?
Sure, good question. So I think aggression is seen in both autism and ADHD, and I think again it can be very different for each individual child, but what we often see for kids with autism who are aggressive, it is often the children who are having communication difficulties, and the communication difficulties they're having result in frustration, and it comes out as aggression often. They want something, and even, I think even aggression is, at the more serious end, it often before that results in just tantrum behavior outside of toddlerhood. We see kids who can't communicate, and their way of communicating is to cry and to get attention in that way. And so often we can reduce some of that frustration and tantrum and aggression by providing them alternate methods of communicating through pictures or through signs if they're not verbal. And so that's one reason we see some of the aggression in autism spectrum disorders. As far as ADHD goes, yes, we do see aggression in ADHD as well, and in many ways that appears related to some of the impulsivity, so that kind of acting before you think, not being able to put on the brakes, and so helping children kind of learn to take those pauses before thinking, before behaving is some of the target of intervention there.
Thank you. Well, when we're talking about ADHD especially, we're talking about a deficit of executive function skills and a deficit in executive function. And Beth was wondering, how is that evident in ADHD and ASD that perhaps executive function is not where it should be at an age-appropriate level?
So executive functions, as kind of the term implies, are some of the most difficult things that we do as people. So executive functions, they're not, first of all, it's not just one thing. You just don't have one executive function. It's a whole kind of variety of skills. Organizing yourself, planning ahead, multitasking. So it's all those things that we expect kids to start to do as they enter into adolescence and into young adulthood. And that's actually maps right onto brain development because executive functioning is for the most part housed in the front of the brain, and the brain, believe it or not, continues to develop into young adulthood, into your 20s, when you kind of hit your peak for a couple years, and then we start to go the other way, unfortunately. But the frontal lobes are the last parts of the brain to really refine themselves, and they're still refining themselves into late adolescence and early adulthood. And so as those functions, as the brain is starting to refine those areas of the brain of itself in early adolescence and again through adolescence into early adulthood, that's when we start expecting kids to be doing some of these things, doing assignments that involve multiple steps. So those more long-term projects. You would never expect a 5-year-old to do a term paper, but they don't have the language, they don't have the planning and organization to do something like that. But we certainly start thinking about them asking kids to do things like that in middle school. We expect them to start changing classes in middle school and having block schedules and all kinds of things that require these executive functions. And so because they're such an integrative thing that we ask kids to do, they're very vulnerable to getting tripped up. And so kids with autism, kids with ADHD, kids with a variety of neurodevelopmental conditions often have difficulty kind of putting the pieces together to be successful in executing these executive skills. And so, we often recommend that you put in some supports for kids to help them manage these executive deficits. And I always laugh because, these are things that we wind up recommending that as adults we rely on every day. We as adults couldn't, well, at least I couldn't, get through life without a planner or a calendar or my Outlook, versus, we think kids can kind of manage and juggle all these things on their own. And so it's just a matter of helping them find an organizational strategy to impose and keep themselves on task. And so, helping to set that up for the child and reminding them to use it and tying a reinforcer to it to motivate them to use it are, all the kinds of things that we recommend to help support these executive functions as they're starting to develop and emerge.
Well, executive function, as you said, is one of the skills that is later to develop as we grow older. And one of the things that often we ask children to do pretty big feats without remembering that they haven't yet made that benchmark. Well, our next question is bringing us over to one about diagnosis, actually two about diagnosis from different directions. One is from Sherry, and she was wondering if MRIs or PET scans or any other type of brain scan are useful in helping to diagnose ADHD or autism spectrum disorder. And then we have Colleen, who is asking, is there an increased chance of siblings of children who have a diagnosis of ADHD or ASD? Do they have a higher likelihood of also being diagnosed with either or both disorder?
So the answer to the first question is no. There is no physiological test, biological test that we can give to diagnose either ADHD or autism. These are diagnoses that are purely based on behavior observation, which includes observing the child, but also includes taking a very good history of what that child looked like through their development. As you could see for both of these disorders, symptoms need to be present, you know, at an early age, and so if we're not seeing the child, for instance, until they're 10, we need to understand what, you know, get a good picture of what they look like developing. But at this point, no, there's no blood test, there's no scan, there's nothing that can reliably diagnose a child with either autism or ADHD. As far as the second question goes, and I can't believe it just left my mind. I'm so sorry.
Don't be sorry, that's fine.
Can you refresh me real quick?
Yes. When there's already a child in a family who's been diagnosed with ADHD or autism spectrum, does that child's siblings...
Oh, I know, the siblings. Okay.
Yes. Yes.
Yes. Yes. Yes. So for kids with autism, there is a 1 in 5, the odds are 20% higher, essentially, that second child, the sibling will have autism. It's not a 20% chance, but it's, you know, there is a greater likelihood that child will have autism. But as far as ADHD goes too, yes, we know that ADHD also has some kind of genetic loading, and so there is, you know, a greater likelihood that it does run in families. It's not, I don't know offhand the number, but of the risk, but I know that yes, for both disorders, it is more likely that siblings, you know, will share the similar presentations, but it's not by any means 100%, but it is a higher risk.
Okay, thank you. Well, we're following up a question we had earlier on medication. As we said earlier, someone had seen that, to her perception, that the ADHD medication had been helpful for one particular child's autism spectrum symptoms, and you said that's not necessarily what research has shown. We're getting a lot of questions. People are very interested in medication management for autism spectrum disorder and wondering, is there medication management? Is there something that does help with this? And, you know, perhaps in controlling ADHD symptoms, do the co-occurring symptoms of autism spectrum disorder have some sort of improvement or other impact seen?
So I think these are all good questions. When we talk about medications for either autism or ADHD, we're talking about medications that will address the behaviors that the child's presenting with. So there is no medication that's going to get rid of autism or get rid of ADHD. It's just going to manage those symptoms while the child's taking that medication, and if the child stops taking that medication, you know, it's possible that the symptoms could return. And so the idea is that the medications relieve some of the symptoms so that behavioral interventions and strategies can be put in place while the child is more available to learn them. And it's really the behavior strategies that are going to produce that long-term effect, essentially. You know, there are certainly children with autism, and again, those are medications that are used to address particular symptoms. And so, you know, if you have particular symptoms, there are particular symptoms that would be amenable to medication or that would respond to medication, that would certainly be something to discuss with your child's medical doctor. To further.
Briefly, Doctor, we had a small glitch in our line, and unfortunately we lost part of what you just said.
Oh,
and
okay.
I try to avoid asking our experts to repeat themselves, but I think our audience, they're very interested in what you're saying. If you could briefly repeat what you had just begun to say.
From the start of the question?
From the start of the question, or... Okay. And I apologize to you and to our participants. There was a gremlin in the line. We've got it taken care of. If you could just repeat that, and we'll continue on.
Sure. So the answer is that yes, children with autism and children with ADHD are frequently prescribed medications. What's important to understand is that these medications are used to alleviate some of the symptoms and the behaviors that the child is presenting with. So it's not like it's going to remove, it's not going to cure the autism, it's not going to cure the ADHD. It's while the child's taking the medication, it's going to reduce these symptoms. And what's important then to understand is that the idea is then to provide the types of behavioral and environmental modifications that are going to produce the long-term outcomes and improvements for the child. So essentially you're trying to reduce some of the symptoms so the child then can participate in the interventions and therapies that are being provided and make progress in that way.
All right. Well, we are still interested. It seems that we have had a slight gremlin again in our line. So, Doctor, we do have another question, and our question comes from Amanda, and she's following up the question about medication with complementary treatments, and she was wondering if there is any evidence that perhaps acupuncture, massage, or homeopathy can help with ADHD or autism spectrum disorder. And for our attendees, one of the things that you can check with is the
and then
there you are. There you are. We had our little glitch returned once more.
I know.
Oh, yes, but that's all right. Briefly, what I was just asking is I'm following up what you were saying a moment ago before we glitched about medication, and Amanda has a question. If there is any evidence that some complementary treatments such as acupuncture, massage, or homeopathy can be effective in helping with ADHD or autism spectrum disorder. And I was reminding our attendees also that at the National Resource Center we have one of our What We Know sheets discusses different complementary approaches, and you're welcome to find that at www.helpforadhd.org. So, Doctor, is there any evidence that this is helpful?
There are certainly, I know that there are parents who will say that different kinds of complementary treatments have been very effective for their child, but for the most part, these are called complementary and alternative treatments because there isn't science yet behind them. I mean, many of them are being investigated currently, but at this point, there isn't the kind of solid evidence behind the more traditional treatments and therapies that have been kind of tried and true that they're to be recommended.
All right, well, I'm going to wrap us up with one more question, and this is from Jacqueline, and she was wondering if there is a difference, if you personally, professionally, and your colleagues have seen a difference between between boys and girls who are affected by ADHD or autism spectrum disorder. Are the symptoms, are the disorders presenting differently in girls, in boys? Are there similarities? What should parents be on the lookout for?
There's definitely literature that describes differences in boys and girls with both autism and ADHD. For instance, girls are more likely to present with the inattentive type of ADHD versus boys are more likely to present with the hyperactive impulsive type. Girls with ADHD are more at risk for mood disorders and symptomatology versus boys might be more at risk for some of the learning disability comorbidities. So yes, there is quite an extensive literature describing the differences for both ADHD and autism for girls versus boys. Some of the evidence, some of the literature for autism spectrum disorders is still emerging. I think it's not quite to the point where the descriptions have been out there for ADHD, but certainly there is some description of kind of the girl with autism spectrum disorder, and she's a little bit different than the boy, but I think it's a little it's not quite as established.
Well, thank you. And the question, thank you for addressing that one. We do hear that often. Both boys and girls can have ADHD. Both boys and girls can have autism spectrum disorder. I'd like to thank you. I would like to thank you so much for being with us today. I think this has been very helpful for our attendees. We've had many questions. I'm sorry we weren't able to get to all of them today. And I'd like to thank you for your time, both Dr. Wodka and our audience. And I'd like to share with you that our next Ask the Expert will be on February 26th at 7 p.m. It's a special time. And we are going to be having Sandra Reif, and she is the author of How to Reach and Teach Children with ADHD. And she will be presenting ADHD in the Classroom, Management Strategies, and Student Supports. And this webinar is geared specifically towards educators, classroom teachers, and school building educators who work closely with students. All of you will find this to be a helpful webinar and a lot of information on teaching approaches and classroom strategies in helping your students cope with ADHD. Registration is now open, and you can register at www.helpforadhd.org and also off of CHADD's website at www.chadd.org/asktheexpert. We hope to see you at the end of the month. Dr. Wodka, thank you very much for your time. And thank you all for participating, and we hope that you enjoy the rest of your day.